Hi, everyone. My name is April Hodge. I'm the chair of the social media committee for the VR SIG. I just want to thank you for joining us tonight, or if you're watching our recording, I appreciate you watching. Just a reminder, we do these Facebook Live events on the first Wednesday of every month at 8 p.m. EST. So please join us live or view the recording. The recordings are also uploaded onto the ANPT YouTube channel. So that's another way that you can view this recording or past recordings if you don't necessarily have access to Facebook, or if your colleague doesn't have access to Facebook. So I'm going to pass the mic at this time over to Carly and let her get started.
All right, well, thank you guys for joining us today. It is my great honor and privilege to introduce a gentleman who needs no introduction, but Dr. Rob Landell, who is PT, DPT, and Catherine Worthingham Fellow of the APTA. And I know Rob through my work at USC, but he is a professor of clinical physical therapy in the Division of Biokinesiology and Physical Therapy at the Herman Ostrow School of Dentistry at USC, where he's Director of Clinical Residency and Fellowship Programs. And with over 35 years of experience treating people with orthopedic, neurologic, and vestibular complaints, Dr. Landell has lectured and trained therapists and physicians in the US, Asia, Europe, Australia, Africa, in managing all of these different patient populations. And he established and was the director of the USC Physical Therapy Associates and continues to treat patients there. So Dr. Landell has published on a variety of topics in orthopedics and in vestibular rehab, and his current clinical interest is in the diagnostic dilemma and management challenge posed by patients with persistent post-concussion symptoms of dizziness. And so today we've invited Rob here to speak to us about cervicogenic dizziness and kind of unlock the mystery of how do we even diagnose and begin to treat this patient population. And Dr. Landell has some great clinical pearls he's going to share with you. And some of you submitted questions on our SIG webpage, so thank you. Hopefully we'll be able to address those. And if you have more questions as you're going through, please feel free to enter those in the chat box so that we can make sure they all get answered. But without further ado, Dr. Landell, please take it away.
Thank you, Carly. I appreciate that introduction. And thank you to the ANPT Vestibular SIG for inviting me here. This is kind of new to me because I've done a bazillion Zoom. I've done so much Zooming that I have Zoom butt for sure. But I've not done the coordination between Zoom and Facebook. So yeah, so like me on Facebook because, you know, my entire existence revolves around being liked on Facebook. So social media, yay. Okay, I'm going to jump right into this because literally we could do a 3-day course on this topic. And actually that's one of the things I do. So to try to kind of get it down to the nuggets in a shorter time than that will be an interesting challenge. But one of the ways we're getting around that is Carly sent me the questions that all of you submitted. And so what I've prepared is really just answers to the questions that I got. And what I'll try to do is go through those and then answer any questions that come up as we go through. So let me try this again. There it is. I think. There we go. Okay, can everybody see that? Is that coming out clear? Okay, great. So just a quick conflict of interest disclosure. So I do, as I said, teach continuing education courses. And one of them is on cervicogenic dizziness, one of the courses I teach. So you just be aware of that. I also treat a lot of these patients. You know, just recently, I actually stepped down as the director of the residential pathway of our DPT program at USC with the intention to go back into more clinical practice. And I think this was very, wasn't planned or anything, but within 2 weeks of stepping down, I got 4 emails from PTs across the country. Hey, I have this patient. Could you see them? Hey, it just turns out that, yeah, I can now. So, so I do see patients, particularly post-concussion, but, typically complain of some form of dizziness. And then often a connection between that and whiplash, neck pain, or a concussive event. And then I created this target, but I don't know that that's a conflict of interest because those are totally free. So I'm not making any money on those things. And they're easy. I made it in Word, so it wasn't that, it's nothing really fancy schmancy there. So let's dive right in. So one of the first questions had to do with pathophysiology. What's the connection between cervical and the visual systems? I'm putting this one right up front because I'm going to start with my weakest area, which is anatomy and physiology and pathophysiology. So I have a pretty solid understanding, I think, of the anatomy and pathophysiology of the region, but mankind is not really clear on the connections between the cervical spine and the visual systems. There are a fair amount of inputs from the cervical spine, particularly from the muscles, but also from the joints. Superficially, skin and so on, don't seem to be many projections into the central nervous system, but definitely from cervical musculature. A lot of the input goes into or connects with the vestibular nucleus, and which is kind of I sort of think of that as grand central station for a lot of our vestibular somatosensory and visual input. And from there, it kind of goes out to a lot of different places. So those connections are anatomically established, but functionally, we're not really sure what the import of that is. So as an example, in the lower extremity, if you have loss of somatosensation, let's say with an ankle sprain, and we know we get that because there's we know if you don't retrain ankle proprioception, it's a higher likelihood of re-injury and so on. So it's a kind of a major part of any ankle sprain rehab program. If we have a lower extremity polyneuropathy, we know we lose some sense of where we are down in the foot and ankle. And the functional manifestations of that are changes in balance. And as I said, maybe some increased likelihood of re-injury. So the question then is, well, if you have that same kind of loss in the cervical spine of the cervical somatosensory input into the central nervous system, what's the functional outcome of that? And we don't have a solid understanding really of those connections. So we have an anatomical idea, but not necessarily a functional anatomy idea. However, we do know that patients with neck pain they don't all have, but they can have problems with oculomotor function. So particularly smooth pursuit when the neck is turned. So there's a test called a smooth pursuit neck torsion test, and I'll talk about it a little bit later, in which you do smooth pursuit and you measure eye speed and relative to the speed of the moving target. And you do it with the head in a neutral position and then holding the head still, turn the body underneath, do it again, and then turn it the other way and do it again, and see if the eye speed to target speed changes. And that's a smooth pursuit neck torsion test. And it turns out patients who have neck pain can have impairments in their smooth pursuit. So there is that functional connection, how it works, what's the pathophysiology. That's a much harder thing to put our fingers on. Let's see. What are some of the key elements of a subjective report that make you suspect a cervicogenic source to the patient's dizziness? All right. I think that's a fair question. So in other words, how do you recognize when a patient potentially has a neck involved? So what are you listening for when the patient's talking to you? So one of the things I spent a fair amount of time in my examination doing is trying to establish the character of the dizziness. So dizziness, we know, is a very generalized term, can mean a lot of different things to different people. So if they say, I'm dizzy, and you ask, well, what does that mean? Or can you explain it? Or you might have to ask some leading questions like, are you talking about lightheadedness? And if they say yes, or if they tell you right up front, lightheaded, then you have to really establish, is this lightheadedness like orthostatic hypotension, which is really pre-syncope, right? So if you continue to have that blood pressure drop, lack of blood to the brain, you're going to pass out. So that kind of lightheadedness is a vascular issue and is not characteristic of cervicogenic dizziness. If they said that's what they're feeling, then I would think maybe there's a cardiovascular problem going on. If they said spinning, what do you mean by dizzy? Are you spinning? And they said, yeah, that moves me away from cervicogenic dizziness. Actually moves me towards involvement of semicircular canals or a central problem. So central vestibular problem. So spinning is vertigo, sense of movement of self or surroundings by definition, but that's our definition, not necessarily the patient's definition. So ask about that. If they say double vision, check their glasses, but consider maybe they're having some oscillopsia or movement of the visual field. And particularly if their double vision is worse or is brought on by head movement, so they don't have double vision when their head is still, but when they move, they see double. And I'm thinking there's a problem with VOR, and that generally, or first, would lead me towards a peripheral vestibular problem affecting the VOR, and then secondarily, if it doesn't appear to be peripheral, then I'd think central. And then, is it a dizziness problem? Is it vertigo, or is it imbalance? So, these days, WebMD, right? I have vertigo. I have vertigo. That's what I have. Okay, well, can you describe it to me? And it ends up actually they're describing imbalance. You need to sort that out as well. So they could use whatever term they use. You need to figure out what they're talking about. And as I said, I spent a fair amount of time trying to nail this down. Now, if they say none of those things, and they say, I feel kind of spacey or off, not quite right, I feel woozy, and in addition, they have neck pain. And the neck pain and these symptoms tend to co-vary. They go up together or they ease together. Then I'm starting to think maybe there's a problem with cervical spine. Time course for cervicogenic dizziness, it can span seconds to minutes. It can get worse or better with movements and things like that, but generally it's sort of always there a little bit. As opposed to BPPV, parallel fistula, orthostatic hypotension, which are all relatively short on the order of seconds. TIAs last minutes. Migraines can last 20, 30 minutes. They could go up to 72 hours, but more often than not, they're shorter. Meniere's disease, episodes of dizziness that last hours or days. Vestibulopathy, attack that lasts hours or days. Time course can help you with that, but it doesn't really help us too much with cervicogenic dizziness. So the key findings to me would be this presence of neck pain. It's not true vertigo. They could say lightheaded, but it's not pre-syncope lightheaded. And really what they're saying, or my sense of what they're saying over the years when they say lightheaded, is their head is actually light, like it's filled with helium. It's a helium balloon, and it's not really connected to my body, and it's just sort of floating along, and it feels light to me. I've heard, a similar thing. It feels like an empty Coke can, or an empty can, or something like that. So, and then the duration, as I said, is variable, or it's movement provoked. They can complain of imbalance or postural discontrol. And then you should, if it's cervicogenic, you should find some musculoskeletal impairments when you go through your exam. So that's not history, obviously, but they will definitely complain of neck pain. Again, the complaints can be non-specific in nature. I'm off, spacey, woozy, those kinds of things. And then in your physical exam, should back this up with no central signs and no history of positional provocation like BPPV. All right, so those are things that lead me towards thinking about the cervical spine as being a point of origin for the symptoms. So what objective measures do we have? What specific nystagmus testing would you expect on VNG testing, and how can an audiologist help? So let me talk about the smooth pursuit neck torsion test, which is, I mentioned already. And basically, as I said, you can compare the target speed versus eye speed. So if you express that as a ratio, target speed over eye speed, or eye speed over target speed, actually, if the eye is going at the same speed as the target, then let's say 30 degrees per second, eye speed 30 degrees per second, target speed, then 30 over 30 is 1. So your gain should be 1. And in subjects who are healthy, smooth pursuit should be, the gain should be about the same with the head in neutral versus a head rotated one way or rotated the other way. But it turns out that patients with WAD or whiplash associated disorders, which is defined as chronic or long-term disability and pain in the head and neck region after a whiplash event. So the gain in the smooth pursuit neck torsion test was reduced in patients with WAD, but not different in patients with central vertigo or Meniere's. So Meniere's was their peripheral vertigo that they were comparing to, or in healthy controls. And so one other thing on this test is, so you have this target moving at a known speed. You have a way to measure the eye speed in the early days using electronystagmography, now video nystagmography. And then the head is held still, so you're neutral. And then in the second condition, you hold the head in the same position and you rotate the body underneath, do your test there, and then turn the body the other way, holding the head still, and do your test there. So that's a smooth pursuit neck torsion test. And because you need to be able to measure eye speed, and because you need to have a target moving at a known speed, the smooth pursuit neck torsion test requires specialized equipment. Now, one of the questions in the previous slide was, how can an audiologist help, right? So typically the smooth pursuit tests are done by the audiologist. So the patient's sent to the ENT, and the ENT makes a determination. I think this dizziness, you know, it's maybe coming from here, but let's get some more tests. Audiologists typically will take care of those tests. So that's how the audiologist would help, particular to a smooth pursuit neck torsion test. But the other thing that they're going to be able to tell you is there a central vestibular problem, or is a peripheral vestibular problem? So they're not going to be able to identify necessarily, oh, there's, you know, cervicogenic dizziness going on, or there's a cervical component to this. But what they will be able to do is tell you it's not central, or it is central, or it is or it isn't peripheral. That's really, really important. Now, in terms of nystagmus for cervicogenic dizziness, no one's ever really described a characteristic type of nystagmus with VNG testing if it's coming from the cervical spine. So I have not read this, and I have not seen anything personally that would help me identify, you know, what some pattern of nystagmus. So certainly it's not as clean and clear as you would have with BPPV, for example. All right. So we have the smooth pursuit neck torsion test. How useful is this test? If the patient has had a history of neck trauma, and it's chronic disability and pain, and they're complaining of dizziness, then sensitivity in one article was 90%, and in another article was 72%. So if the sensitivity of the test is decent, so that's what the SN is, and you do the test and it's negative, that's what the N is, then you can rule that condition out. So we can snout it out. So at least based on one of the studies, that should be a superscript. Based on one of the studies, had a sensitivity of 90%, which means that if you do the test and their gain is the same in neutral and in rotation, then we can say they probably don't have WAD with dizziness. It's not coming from the neck. And then the specificity was 91 or 92 in these two studies. So if the specificity is high, then we do the test and it's positive, then we can rule the condition in. So we can spin it in. So we do the test and we find that the gain changes from the head neutral position to the head rotated position, generally decreases. And if it does decrease, that is specific for or rules in patients with WAD and dizziness. So if they don't have the dizziness along with the whiplash-associated disorder, then the sensitivity is not great. It's basically, we could just say that's useless. So this is why I said earlier they have neck pain with their dizziness. It's one of the reasons why we would say they need to go together. So what does this mean? It means if you have this test, you do this test, it may be useful in identifying whether the patient has involvement of the neck with their dizziness. It may or may not be useful in helping to rule out the neck being involved. So, but at least it can give us a nudge down one direction or another. Okay. I'm going to pause for just a second, and I don't see anything in the chat. And Carly, you go ahead, or any of you go ahead and just interrupt if there are questions showing up in the chat. But I'm going to encourage you to, if you have questions, or I'm going too fast or whatever, to go ahead and throw those in there, and I'll answer them as they appear. So another question had to do with the objective exam. What is your go-to test during the evaluation to rule cervicogenic dizziness in or out, right? Everybody wants, what's the bottom line? I just want to do one test. I want to do this, I don't want to do that. Unfortunately, there is no single test. I would say that if you have the opportunity to do it, the smooth pursuit neck torsion test would be a good test to have done. I'll be completely transparent, though. There is some controversy in the literature about whether or not the smooth pursuit neck torsion test works. And the controversy has to do with, it's a similar one actually that is occurring in EMG. If you do a computerized assessment of the nystagmus versus a assessment by eye. And those who do it by eye say that it's useful, and those who say it's computerized don't, and they have their arguments on the technique and so on. So take that with a grain of salt, that test with a grain of salt. I think I'm not going to hang my hat on it, but I am going to let it sway me towards treating the neck or not. But I'm also going to put that together with everything else that I do. So, and I'll talk about what else I do in a second. So smooth pursuit neck torsion would be great, but you need, you need the equipment to be able to do that well. Having said that, not so much the testing on the objective exam, but the history is going to tell me where I want to go. And this really, if you think about it, it really should be your goal all along. So in medicine, they talk about 90% of the diagnosis should be made on the history. And the physical exam should be something that helps you confirm or disconfirm the hypotheses that you end up with after the subjective exam. And I think the same is true with cervicogenic dizziness, that you really want to have a good subjective exam and to identify where you're going with the patient. Having said that, there are a couple things that you might try that might help you. And I'm going to throw this up here first and just point out the fact that this has F-level recommendation, strength of recommendation in the most recent concussion clinical practice guideline that came out in April of 2020. So this is specific to the dizziness complaints that patients the dizziness complaints that patients complain of. The dizziness complaints that patients will tell you about after having suffered a concussive event. So our suggestion, and this certainly is my clinical practice experience, is trying to add traction to the patient and seeing what that effect has on the patient's symptoms. So in this picture, you can see what I'm doing is I have stabilized the patient's head, and I'm trying to contact only on the occiput, trying to stay off the chin and jaw. Support the head, let the patient lean into me, and then rather than me lifting up with my legs, actually what the patient does, the patient just sort of slumps or relaxes, drops down, and then I just hold her head there, and I don't let her head go with it, which results in a traction force or a superior force on the head and neck. And if you keep the head relatively still, with as little change as possible in the orientation of the head in space, then you're going to reduce or eliminate any vestibular stimulation. And if they get better, their symptoms ease when you do this. It's hard for me to say that this is coming from anything else than the cervical spine. So to me, this would be a go-to test to identify if the cervical spine is involved or not. Now, this has not been looked at all. So you're definitely in F level recommendation is expert opinion. So it's not backed up by any research data at all, even cohort studies or case studies. But it does have some validity, in my view, some face validity in that it's really hard, if you're careful when you do this, to say that symptoms change came from anything else than the traction of the neck. Now, some patients, this is a vestibular SIG, so you may know this already, when you stabilize their head, or you stabilize their head and neck, or you stabilize their body, you give them a lot of somatosensory input in some way, a lot of times they will feel better because that increase in somatosensory input really allows them to establish, oh, this is where I am. This allows me to have some frame of reference for where I am and what I'm doing, what I'm moving. And their symptoms will reduce. So to really make it clear that this is from the neck, you want to change one variable at a time. So you don't want to hold on to the patient, stabilize them, and add traction, because then if it changes, you don't know what changed it. So what instead, come around, stabilize them, and just hold them there without any traction and see if that changes their symptoms, and wait for any change to stabilize before you ask them then to slump, drop down a little bit, and add your traction. So that's how I go through that. And I think this is really important. The last thing I would say about this is you do the traction in the position where they are symptomatic. So in this case, patients complaining of some low level, let's say 3 out of 10 dizziness while she's sitting there. So I just come back behind her and add the traction in that position, and she goes, okay, that dropped down. I've had patients who you do some, their aggravating factor is walking. So they walk across the room, they come back, okay, now I'm dizzy. In that standing position, as cleanly as you can, just try to add traction to the neck. Don't try to change anything else and see if that changes anything. Certainly if the patient lays down, oh, now I'm dizzy, add some traction, see what happens. They tilt their head to the side, now I'm dizzy, add some traction, but add it in that same direction of their head tilt, and see if things change. So be creative with this, but be as specific as possible to only changing the neck, and then assess the symptomatic response. All right, so the next question is, how do you differentiate between cervicogenic dizziness and a vestibular migraine? Okay, so we're lucky here in that the International Headache Society does have some criteria for this. So here's the dilemma. You have a condition, cervicogenic dizziness, that implies there's a problem in the C-spine that's causing the dizziness symptoms, right? Cervicogenic dizziness coming from the C-spine. If you think about that for just a second, that's not a diagnosis, that's a complaint. That's like shoulder pain, pain coming from the shoulder, cervicogenic dizziness, dizziness coming from the neck. But it implies that the neck is causing in some way those dizzy symptoms. Well, a lot of those impairments that could be causing the dizzy symptoms can cause other symptoms as well, like headaches, like neck pain. So now you got this condition, migraine headaches. And we know migraines can cause headaches and migraines can cause dizziness. So you have your more classic migrainous headache, but you have vertiginous migraines or migrainous vertigo, whichever. So that creates this dilemma of trying to differentiate between the cervicogenic dizziness or dizziness from the C-spine and dizziness or vertigo coming from a migraine. So as I said, the International Headache Society has their criteria. And if you want to get your phone out and use the QR code, it'll take you right to the webpage, or you could just Google IHS headache criteria. And what you do is you'll get into, it's a primary headache, and I think it's 6. It's A16.6, something like that. Anyway, you have to scroll down a little bit to get to it, but it's cervicogenic dizziness is actually in the appendix. So that's A, and then it's primary, so it's 1, and then it's 6.6. So it's A1.6.6. Anyway, use the QR code, much easier. And their criteria for cervicogenic dizziness is at least 5 episodes fulfilling these criteria. So you have to have a current or past history of their classification 1.1, migraine without aura, or 1.2, migraine with aura. And then they have to have vestibular symptoms of moderate intensity, moderate to severe intensity, lasting between 5 and 72 hours. And at least half of the episodes are associated with at least one of the 3 migrainous features. So headache with 2 of the following 4 characteristics, or photophobia and phonophobia, or visual aura. Okay. So let's see. So these are the notes here have to do with how they describe vestibular systems. So vestibular systems are defined as including spontaneous vertigo, positional vertigo, visually induced vertigo, head motion induced vertigo, or head motion induced dizziness with nausea. So any of those vestibular systems of moderate to severe intensity. So moderate is when they interfere with but don't prevent daily activities, and severe is when daily activities are also it's intense and it interferes with daily activities. And then between 5 minutes and 72 hours. So that kind of gives you a sense for the variability of the duration. And that's why, going back to my slide on the duration or the time course, not really useful in cervicogenic dizziness. It's not useful in migrainous vertigo either. To me, that's too wide a window. Let's see. Now, as far as having at least half of the episodes, so they had to have 5 episodes. So at least half, that would mean if they had 5 episodes, then 3 of them had to at least one of these migrainous features, either headache with headache, or photophobia, phobia, or visual aura. Let's see. Now, any one of these is sufficient given any single episode. So you could have different symptoms in different episodes, but you need to have one in one of these characteristics in at least half of the episodes. So if you've had 5 patients had 5, then they've had to have 3 where they also had these one of these symptoms. And then the last caveat, which is classic for pretty much all criteria, is you pretty much ruled out other vestibular disorders, or you ruled out other disorders that could be causing, these signs or symptoms. So in that sense, it is still a bit of a diagnosis of exclusion. Okay, so hopefully that covers adequately the difference between cervicogenic dizziness and migraine vertigo. Sorry, you know what? I just realized this big typo here. I totally ignored this, but it's not benign paroxysmal vertigo. I apologize. Oh wait, no, I'm good. No, yeah, right. Sorry. Yes, I'm good. Sorry. So what I was just talking about is migraine vertigo, cervicogenic dizziness. There is another condition called benign paroxysmal vertigo, but that occurs in otherwise healthy children. So again, you can use a QR code to go to the BPV criteria, but this is really in children. So, and I wasn't clear in the question if you're talking about adults, we're talking about children. So just one thing here, again, it's 5 attacks fulfilling criteria B and C. This would be this is A, B, C, and so you'd have to have nystagmus, ataxia, vomiting, pallor, fullness. Now, the thing with children is they may be experiencing vertigo, but not be able to describe what their symptoms are, because we're talking about children. So you may have to rely on parental observation of these episode periods of unsteadiness. That's maybe what the parent sees, where the child doesn't really complain of anything. So I threw this slide in here because I wasn't clear if you were talking about adults or kids. And this is another one that's sort of a kid's migraine vertigo.
And just to clarify to Dr. Landell, that is BPV, not BPPV. So that's a separate condition, just to make it even more complicated.
Yeah. So this is not positional vertigo. This is benign paroxysmal vertigo. And it's, again, in kids. So great. Thanks for that. Another question, what is the best way to differentiate cervical vertigo from concussion or unilateral vestibular hypofunction? So the QR code here will take you to the concussion CPG, which is freely available to download. And I highly encourage anybody who's treating people who are complaining of dizziness to get this, because all right. So we'll get patients who are referred to us as PTs with a diagnosis of concussion, right? And usually they end up going to see someone with a healthcare provider with a neurologic background, because concussion is always sort of equated with the brain injury. But I would be hard pressed to try to identify, and I would challenge you to try to identify a traumatic event that's significant enough to damage the brain that wouldn't also be significant enough to damage the neck. And so you get a patient who is referred for concussion, diagnosis of concussion, where the neck is involved and hasn't been identified as a contributing factor to the patient's symptoms and dysfunction. On the flip side, at the other end of the spectrum, you have patients who were referred to us with neck pain after whiplash, so whiplash-associated disorder, or acute neck sprain, or whatever. And it's equally likely that if they had enough force to damage the neck, they had enough force to damage the brain. So it's really important, I think, to get the concussion CPG and to understand the things that we're talking about in there. And we put in 4 domains to look at, and the one that's most applicable, the 2 that are applicable to, I would guess, this crowd, are the musculoskeletal domain and the vestibulocular domains. So we recognize in the CPG that those 2 domains are part of the signs and symptoms that patients present with after a concussive event. So, for concussion, go see the concussion CPG, and I'll talk about that a little bit more. And then unilateral vestibular hypofunction. There are clinical tests that you can use, the head thrust DVA, which should identify patient with a unilateral vestibular hypofunction. Gold standard would be your ENG testing. There is another CPG. I just realized I didn't put the QR code, but you can do a quick search for the CPG for managing UVH, and should be familiar with that. So the interesting thing as PTs, because we get patients from a lot of different sources, and they present with a lot of different signs and symptoms. And when you have a patient who's complaining of dizziness, the dizziness can come from a lot of places. We kind of have to be experts in a lot of areas. So you probably need to have a lot of CPGs in your back pocket or on your phone or whatever, or in your brain, even better. So you can assess these. But just to go back to UVH, so we have our clinical tests that should identify for us if the patient has UVH. The head thrust and DVA, the key things here are you're moving the head, and because you're moving the head, you're moving the neck. And because of that, the sequencing, and we talk about this in the concussion CPG, the sequencing that you need to go through includes clearing the C-spine before you do those tests. Most obviously to clear the fact that they may have pain when they move their head. Certainly you don't want to passively move somebody's head into a painful range of motion or in a painful direction. So you want to clear all that out, and before you do your head thrust or your DVA. The other thing that we talk about in CPG, which I think it would be instructive if you haven't looked at it yet, is the concept of irritability, and identifying how irritable they are, and based on the irritability, deciding how aggressive you want to get with your tests. And the other thing we talk about is in our view, the sequencing that makes sense would be, if the patient's presenting with neck pain, decreased range of motion, other impairments in the C-spine, that it makes sense to us to clear those up before you proceed to doing any vestibular exam or rehab, because so many of the vestibular tests potentially could annoy an irritated cervical spine. So our priority would be, let's manage the pain, let's improve range of motion, let's deal with some of the C-spine impairments. And then as tolerated, then we can move into our tests for the vestibular system and in our treatment as well. So beyond what we've talked about so far, how can we differentiate the difficult presentation, right? So these are patients, and since this is a vestibular SIG, I can't see your faces, but I'm gonna assume when I say this, a lot of you are gonna be nodding your heads. How many of you have seen a patient, for example, who was referred for BPPV, and they had a positive Dix-Hall pipe? So you treated that with a repositioning maneuver, and they sat up and they felt better. And the next day they reported, hey, I can roll over in bed and I'm not spinning anymore. So that's awesome. I feel much better than I did because I'm not spinning, but I still have some symptoms, and those haven't resolved. Well, look, redo the Hall pipe, it's negative. Neurologic exam is negative. Maybe they had an MRI. That's all fine. Their brain actually is in there, and there's no abnormalities on the brain scans. C-spine X-rays are normal. MRI of the neck is normal. Everything normal. And yet the patient is saying, I don't quite feel right. Happens quite frequently, to be honest with you, right? So how do we now proceed with that patient? Where are the symptoms coming from if all the tests are equivocal? So I already talked about C-spine traction. I put the slide in here twice on purpose because I think that would help you a lot. So something to play around with. And the other thing that you could try is the head neck differentiation test. So in this test, you have the patient, in this case, the patient looks to his left and he gets dizzy. All right. So where is this dizziness coming from? What's provoking it? Is it the head moving to the left in space, or is it the neck rotating to the left? Since he's doing both, you can't tell where the symptoms are coming from. So again, this is the complicated patient that you're having difficulty differentiating. So we're going to step way, way back in our thought process, way back. And we're going to divide the body into two, head and neck, and very globally, just whatever's in the head, whatever moved when the head moved, and whatever moved when the neck moved. And we're going to go with binary PT. It's either this or it's that. And that's our thought process right now. So we can't tell when he does this, was it the head movement or the neck movement? So we're going to do two things. We're going to hold his head still and then have him rotate his body underneath. And by rotating his body underneath to the right, he ends up in the same left rotation of his neck that he had when he had his symptoms. And we asked him, does this reproduce your symptoms or not? Now, this is known as the Nectarine Nystagmus test. It's been described for many decades in manual therapy books and articles and things like that. And the idea here is that if you hold the head still and you move the neck underneath, then if the patient complains of symptoms, then that implicates the neck, because the neck is what moved. Now, what's interesting here is, and that people don't talk about it and recognize, is that you haven't really assessed the head. So you could say, yeah, I think the neck is problematic. But how do you know that moving the head isn't also problematic? Now, if you get negative findings, this becomes even more clear, this dilemma. You hold the head still, move the body underneath, and the patient, that's fine. All you can do is infer that it was the head movement that caused the problem. You can be reasonably confident that the neck movement didn't cause it, but all you can do is infer that the head was the issue. So it turns out that this isn't really that useful. So it has been shown to not be very specific for cervicogenic dizziness, because up to 50% of patients without cervical pathology have demonstrated nystagmus with the test. So if you think about it, what if there were a coexisting vestibular problem? So in other words, a problem in the head. You wouldn't know if there was one if you just stopped at the Nectarine Nystagmus test, because all you've done is move the neck. So what I would argue is that we need to do something more than the Nectarine Nystagmus test. So we're going to do this modified version of that, which is the head-neck differentiation test. So that's what I've called it. There are some articles now coming out. There's one actually in 2020 in Physical Therapy by Julia Trelevin and co-authors, but they do theirs differently than mine. So I'm just going to describe to you what mine looks like. And we can apply this test not just to rotation, but flexion extension, quadrant positions, other provocative positions. So essentially what we do is we do the Nectarine Nystagmus test. We identify whether neck movement is causing symptoms. Then we do this second maneuver. So we're going to stabilize the head and neck, and we're going to turn the body, head, neck, everything together as one piece. In this case, again, to the left, because that was the direction that the patient complained of symptoms. So now all we've moved is the head. The neck has not moved. And if we're careful, the neck has not rotated at all. Now, if that causes symptoms by rotating the head and neck together, then we would say, the head is really suspicious. So maybe the vestibular system, for example. If we only did this test, we wouldn't know if the neck was involved because we didn't move it. And if we get negative findings, then we say, okay, maybe the head movement wasn't what caused the symptoms. But again, if all we did was this part of the test, we couldn't make a statement about the neck at all. So what I'm arguing is that you do both of them together, and by doing them both together, you can rule in the neck, rule out the neck, rule in the head, rule out the head as being involved or being provocative for their symptoms. That's something that I found useful clinically. to at least move me down the road towards, I think the C-spine is involved. Let me go back and check and see what's going on there, and address some of those things there. Or the neck comes out to be negative, right? Let's go look at the head. Maybe this is more of a habituation kind of a situation, where habituation exercises would be best for this patient. And then the other nice thing is, now we know if the head and the neck are both involved, now we know we have to treat both. So there you go on that. All right. So that was just a discussion to that goes back to this question of best way to differentiate C-spine from concussion or UVH. And concussions are tough because, again, difficult to separate out if it's the problems are due to the brain injury or to a neck injury or to a injury to the vestibular system. All right. So I had several questions on treatment. What manual techniques have the best outcomes in this population? And what advanced cervical strength techniques are recommended beyond isometrics when someone can't do planks? And finally, what are the best materials to educate patients? This question apparently comes from someone in a small rural town with one way overworked medical office. So getting them to educate is tough. Okay. Here we go. So there was a systematic review. It's 16 years old now, and there have been other studies that have been done since. But all the studies that they looked at that time had a positive result, but they also had low methodological quality. So one of the conclusions of the systematic review was that RCTs are needed. And then the treatments included joint mobilization, so both passive and active joint manipulations, and then soft tissue treatment to the soft tissues. And so their conclusion was that manual therapy should be considered in the management of cervicogenic dizziness. So that's evidence that we have. We also have some good RCTs that demonstrate some positive results, short and long term. And this is one of them. Same author, Reed. There's 3 articles that looked at sustained natural pathophysiological glides. In this case, we're applying the snag to the left articular pillar. As the patient goes into right rotation, the left side should move away from us. So we're just going to sort of follow the articular pillar on the left side as she goes into right rotation and just sort of help it along, add a little overpressure at the end. It's all about the movement. So mobilization with movement after mulligan. So she moves repeatedly over there, and just give her a little extra nudge as she goes through the range and at end range to help it along. And that has been shown to reduce symptoms and improve range of motion and reduce pain as well in patients with cervicogenic dizziness. So, so that's one definitely in my toolbox. And as for the education, boy, you know, Vita has a nice article, again, a QR code that'll take you to that, but you can search education, cervicogenic dizziness, and you'll get to Vita, or if you add Vita, you'll get there faster. But as far as like articles or resources, things like that, you know, I don't really have those anything handy that. So I'm sorry, I'm not going to be too helpful with you on that. But hey, what I would say is maybe that's a challenge to the vestibular SIG to produce some.
We have one. I was about to say, we have a patient education fact sheet. So we will post a link for you guys. There is one on cervicogenic dizziness, right? If you go to special interest groups on our SIG page, patient education fact sheets, we do have a cervicogenic one. So we will post the link in the comments for you guys.
There you go. There it is then. All right. And that was my last slide. So I am open to any comments or questions. It's 5:55, so that went about an almost an hour.
We did have one question about, so I know you mentioned that for the smooth pursuit neck torsion test, that would need to be done under VNG, but we had a question, is there a clinical approximation for maybe if you don't have access to something to measure the gain?
Yeah, all I can say is take a card, write something on it, or have something with some writing on it, right? And hold it in front of them and have them read that. So that would be just stable, get a sense for their visual acuity, right? And then with their head still, move the card back and forth and have them read to you, right? So if they are able to follow the card with their eyes appropriately, they should be able to continue to read the card, right? And then you can repeat that again, hold the head still, move the body underneath and repeat it over here, and then rotate another way and repeat it over here. So we don't have, so it's sort of a dynamic visual acuity, but it's a dynamic smooth pursuit test, I guess you could call it. You can't make any statement about, this is good or this is bad. All you can say is, man, it seems like you're having trouble with that. Maybe we should send you to the audiologist to get tested. So it would sort of nudge you in that direction to maybe refer out to get a little bit more testing. And then one of the things I do is they start reading, and if it's short, they know what it says already. So then I have them read it backwards, or just to mix it up so that they're not too familiar with whatever's on the card. So that would be my clinical approximation of the SPNT.
Wonderful. And then to a related question, are you assessing symptoms as the patient is performing this?
The smooth pursuit neck torsion? Mm-hmm. Yeah, you can, but if their head is still and they get symptomatic with that, that's not cervicogenic in my view, because their neck is not moving, only their eyes are. And so it's an oculomotor issue, or it's a problem with visual motion sensitivity. So the next thing I would do is I would take something out in their visual environment and move that. So you could use the OKN strips, or take a checkerboard, or take a piece of cloth with vertical stripes on it. There's an app called OKN strips that you could use. But anyway, some motion in the visual environment and see whether or not that causes symptoms. In any case, if the head and neck are still, eyes are moving, they get symptoms, that's a central problem.
I will say in my experience, I do find that that's the case. But then if I'm also dealing with cervicogenic symptoms on top of like a concussion, where they might have some ocular motor symptoms, and then I put them into cervical rotation and have them complete those exercises for oculomotor smooth pursuit or saccades, then sometimes their symptoms can be worse in right or left rotation. And then that way that I know, again, that it's not just the ocular motor symptoms that's going on, but also a cervicogenic component.
Right. So in that case, it's a good point, because in that case, we've changed the cervical condition, and now they're more symptomatic than when they're in a neutral position. Or let's say you stabilize their neck, put them in a collar or something, or just do some manuals, and the symptoms are eased, or you do traction and have them move their eyes and their symptoms are eased. All those things would tell me that the neck is involved in some way. So generally when I'm doing smooth pursuit activities, I stabilize the head, or at least give them a cue to stabilize the head to try to take that out as a variable. Because you probably know this, as if you don't stabilize the head and you move in a target in front of them, their head will move a little bit. And if they get symptomatic, how do you know? Was it the eye movement? Was it the visual surround? Was it the neck movement? Was it the head movement? You got too many variables there, and you can't say which one is coming from. So try to control the variables by, in this case, stabilizing the spine. It's a good point.
Wonderful. Well, a big thank you to Dr. Landell for being here today to spend some time with the SIG and help us answer some of these questions. If you continue to have more questions, please feel free to post in the comments, and we will try to answer these questions, just maybe posting in the SIG over the next couple of weeks. So on the SIG website, on our Facebook page and our Twitter, but check back for more. And again, big thank you to Dr. Landell.
You're quite welcome.
Yeah.
I look forward to the day we can actually do this and I can actually see who's there and we can have a conversation, much more organic way of presenting all this stuff. So look forward to that. Hopefully I'll see people at CSM. If you see me, say hi. And I'll get my courses. COVID sort of destroyed my courses this past 2 years, but 2022 we'll have our courses up and running again, and they'll be blended online and in person. So look for those too.